नमस्ते सर.
कसे आहात तुम्ही? हाउ आर यू?
बिल्कुल ठीक सर, बिल्कुल ठीक.
Thank you, ma'am. Thank you for.
Madam is a teacher to practically every generation of retinal surgeons in the country. And is Avinash, Dr. Avinash here?
Yeah, there.
Hi.
TNT.
Avinash and me were bandits in hands when we were fellows. We have done all the possible mistakes as Retina fellows, right, Avinash?
Yeah, you want to talk about it or stop?
So that will require another conference. And Dr. Manoj Sasade, sir, welcome. Again, a most dynamic, prolific vitreoretinal surgeon of Maharashtra. Then I would like to welcome Dr. Himanshu to the panel and our own star, Dr. Sapnesh. You're moderating the session.
Yes, sir.
I can see Dr. Parveen there on the screen. Hi, Dr. Parveen.
Hi, Preetam. How are you?
Very good, very good.
Doctor,
Can I interrupt this session for a minute? I know that the session needs to be on time, but since Swapnesh's teachers are over here and Preetham's friends, I must say that this whole program is completely the baby of Dr. Preetham sir and his baby, Dr. Swapnesh. And I thank Dr. Lani sir. Please continue talking, but I would just say thank you to everybody for being here and for the scientific work that you all do. Thank you so much. Dr. Lani sir.
Yes, true, because the Pritam and Swapnesh, they have done a wonderful work for the total session throughout the day today. They have contacted, they have taken the all the talks and everything, and really I am proud of them. With Ragini, they have done a wonderful work. So really I want to appreciate both of them when their teacher is sitting here. So I want to appreciate ma'am. You don't know, both of them are working with me, and I am very much proud of them that they are very good retina surgeon. How much good when we will meet, I will tell you, but they are very good, definitely. Best wishes to them.
Sir, it's just joking. They are the best, ma'am.
I don't need to be told that. Okay, sure.
I can see Dr. Unni on the screen.
yes.
Yeah, Unni is there.
Hi.
Yeah.
Hi, everyone. Thank you for the invite.
Rupak is there. Rupak, hi. Dada.
Unni is also there. Welcome, Unni.
So, Sapnesh, over to
Yeah,
you. Take
sure.
over. Go ahead.
So I think without much ado, we'll begin this session. It's titled as Medical Retina for Day-to-Day Practice. So as our symposium is attended all over Maharashtra and beyond, many general ophthalmologists would like to know what are the recent advances in medical retina and what are the take-home messages. So we have none other than Dr. Muna Benne madam as the chairman and Avinash sir. So over to both of them to start the proceedings. And Parveen madam, please share your slide as Muna madam just introduces. Dr. Avinash sir is going to introduce Parveen Sen madam.
Yeah, I guess thanks, Swapnesh, for that. And we welcome the entire panel and the esteemed team of BOA and MOS for giving us the entire team for this opportunity. Now, so the first speaker, we all know who she is. She's a senior consultant and heads the electrophysiological and diagnostic lab at SN. So over to you, Parveen, for your first talk on gene therapy.
Thanks, Avinash. And I start this talk with regards to the BOA team who has given me this opportunity, and especially Dr. Preetham, both of us who have been colleagues together as fellows, and Swapnesh, who has been a very able and a dear student. And it's nice to see him take so much of responsibility on a national level. So the topic for today for me is on update on gene therapy in inherited retinal disorders. It's a little dry topic. I will see how to make it a little interesting and relevant. And it has been, the buzz has been around, especially because since the FDA approval was given for gene therapy for RP65 retinal dystrophy, both for LCA as well as retinitis pigmentosa. And this was thanks to a lot of work by Jean Bennett and her team. And so does that mean that we are seeing a game changer? And Yeah, so does that mean that now we are only going to talk of genes and they hold the future for us? Well, this is the beginning of a precision medicine, and gene therapy is probably going to be a perfect platform for this kind of precision medicine. And retina specialists are leading the way in this because retina is an ideal target for gene therapy. It's a small organ, self-contained, accessible, easy to image non-invasively, and you can follow up the patients after this treatment, and it's a relatively immune privileged organ. You can treat one eye and the other eye can act as control. So retina is actually a window to the body, and many monogenic disorders are there which can be treated and targeted. So in light of this new information and new standards, what is our new standard of care for inherited retinal diseases? Can we just send them to a low vision clinic and tell them to come for a follow-up at once in a year and leave it at that? I think we need to do something more for these patients now, beginning with early diagnosis and characterization of disease, genetic testing, and some familiarity with the ongoing clinical trials. So the clinical characterization can be in form of history, visual acuity, fundus imaging, and other tests, wide field photography, autofluorescence, and spectral domain OCT is probably on the top of the list, which should be done for all the patients who come to us as a baseline. And now, since all of us almost have access to these, the patients with inherited retinal disorders should also have these tests at least once done in baseline. And if you have access to the other tests, they should also be done. This characterization helps in establishing phenotype-genotype correlation. And you'll be surprised when more and more patients you see, you may be reaching a stage where you see the fundus and you may think of what could be the underlying gene. For example, on the extreme left, if you have this large colobomatosis kind of macula, definitely there's a high chance that it is the RDH12 mutation which is causing this kind of a retinal dystrophy. So are we going to do genetic testing for all patients? There are almost more than 250 different genes which can cause inherited retinal diseases. And to add to it, our IRDs as a model of complexity. As we know, RP can be caused by more than 100 genes. Same way, phenotypic heterogeneity means ABCA4 we know can cause Stargardt's as well as RP. And we also know PRPH2 in the same family can cause pattern dystrophy in one person, RP in the other, and vitelliform macular dystrophy in the other member of the same family. So do we really need to do this also? Well, yes, it helps. It helps us to rule out syndromic diseases. It helps us to determine inheritance and prognosis. And it can help us to tell whether the patient can be included in a clinical trial. So looking at all this, the AO task force recently in a position statement in 2016 did advise that genetic testing should be done for monogenetic diseases such as RP and Stargardt's, and definitely should be included when you are looking at diseases like LCA or early onset RP, where gene therapy has been approved by the FDA. In patients who have autosomal dominant or X-linked inheritance, it is very important because of genetic counseling and for future planning in the family. So once you decide on doing the genetic testing, how do you go about it? Which lab do you approach? So these are two important standard labs in the country where we are sending out specimens. I have no financial interest, but just to give you a little guidance. And which type of gene test would you like to do? So as I said, more than 250 genes are involved in IRDs. You may not know single gene which test to do. So you have the option of either doing a gene panel or you have a whole genome scanning. Whole genome means the whole chromosome genetic material will be tested. But when you do this whole genome testing, it is very expensive, more time consuming, and a variant of unknown significance will be coming up in your test, and you will not know whether they are really truly associated with the disease. So gene panel is a good compromise where about the important genes which are known genes which are there with the IRDs are tested. Even this test takes about 3 months time. And once you get the test report, you cannot just give it to the patient, but it comes with a lot of responsibility. You have to have a geneticist or a genetic counselor with you, whom you are alliancing with, and he or she needs to take up this genetic counseling for the patient. So we know that most of our clinical trials have BCVA or the ETDRS letters in which they measure the results that you give this injection and these many cell ETDRS letter is the improvement. But that does not work for patients like RP or LCA because the vision is already very, very poor and the aim is to improve ambulatory vision. So these tests test nothing but the reading vision or the mobility or navigation vision. So this is a slide which I have borrowed from the Novartis. This is something called the multi-luminance mobility test. So this tests the mobility of the patient in different levels of illumination. So 1 lux is something like a dark night, 400 lux is a illumination, a well illuminated room. And an MLT score of 2 or greater is considered to be a meaningful improvement in functional vision. So we see that with this advent of gene therapy, our understanding and the way we talk and look at the patient is going to change. So what kind of gene therapy are you going to offer the patient? Usually if you have a recessive gene, the disease is caused by loss of function. So you add that gene. In a dominant disease, you may have to remove the faulty gene. And we are at this point of time far away from genetic therapy for multifactorial diseases. So in augmentation, the most common disease which has been treated is the RP65 gene, which is known to cause LCA. And this is how it is done by using the virus vectors. This is something which we all know. I'll just briefly touch upon this, that the genetic material is used, the gene, the good gene, which is put on to the delivery vehicle, and the route of administration can be intravitreal or subretinal. And the common viral vectors used are the AAV, and this is the one which has been used for LCA and choroideremia and the other genetic disorders. Larger genes like ABCA4 or the Usher gene need larger viral vectors, which is the lentivirus. So it is basically the size of the gene which determines what virus you have to use as a vector. So this is what has been used for subretinal injections. And the procedure is after a core vitrectomy, PVD induction, subretinal injections are given. And it took almost 2 decades for it to reach from the lab to the clinic and FDA approval. The phase 3 trial had almost 29 patients, and they did mention that these patients were able to maintain some ambulatory vision, and long-term trials at 5 years have said that the results are encouraging and they're able to maintain ambulatory vision. These results, they have also said, are better in younger age group than as compared to the older ones. So for autosomal dominant, you need gene inactivation, which can be in form of deletion or gene editing. And this is where the CRISPR technology is used, where they cut off or slice the abnormal area and replace it with the normal segment of gene. But it has its own ethics which are involved, because it cannot be just for treatment, it can be used for other reasons as well. So here, information about the number of trials which are ongoing at this point of time is for Usher disease, for choroideremia, for X-linked retinoschisis, for achromatopsia, and for RP related caused by Merck gene as well as PDE6B. Information about these genes trial is important, that once you have the genetic testing and the patient tests positive for these genes, you can offer the patient that he can look into and see if he wants to get enrolled in one of these clinical trials, which will help him, he has to decide whether he really wants to go with it and do it. So if we want to remain up to date and current, I think genetic testing has to be adopted in our clinical practice. And I don't think we can anymore say that it's financially not viable. Gene panel testing nowadays costs nothing more than 15,000 rupees to the patient, which is a lifetime test, and vis-a-vis the injections, which we give almost 1 month. I think this is peanuts. So, but therapy, yes, of course, is still a long way and still not something which everybody can afford. Maybe we will see some changes on it next time when it comes to India in a major way. So with that, I conclude this, my talk. Thanks a lot. Thank you.
Thank you, Parveen, for a very informative talk where you stressed on the genotyping is important once the diagnosis is made, and what is in store for us in the future in these diseases which we don't have current treatment available in our clinical practice. So thank you again. So we move on to the next talk, and the next talk is going to be on lattice breaks, retinal detachment, and refractive surgery. What do they mean for vitreoretinal surgeon? And talking on this topic is none other than one of the teachers who we all endeavor, and also happens to be the senior consultant and deputy director at Retina Services of Shankar Netralaya, Dr. Munna Bende.
Thank you, Avinash. And can you hear me and see my slides?
Yes.
Yeah. Thank you to Swapnesh and Preetham for involving me in your program. It's a little unusual topic in the session, but I think most of us find it's a very practical one as well. So what exactly do all these mean for a VR surgeon, especially in the era of refractive procedures and more topically, the large litigation that all of us would have read about recently? I'm sorry. So my talk will ask the 3 questions and try to answer it. What is the risk of retinal detachment in myopia? Why does it occur? What is the procedure that is planned for correcting the refractive error? Does the risk change? Which eyes would I choose to treat? How long is a safe gap? And what are the problems I would face as a retinal surgeon in an eye with an RD that develops post-refractive surgery? So coming to the risk of retinal detachment in myopia, the early incidence of retinal detachment ranges from 0.015% to 0.075%. And in a population-based study, it found that the Chinese individuals had definitely a higher risk of myopia compared to Malays and Indians. And in the eye disease case control study, they found that patients with high myopia may have a 10-fold increase in retinal detachment risk, and more than half the cases of rhegmatogenous retinal detachment which did not undergo surgery could be attributable to myopia alone. So myopia does form a very high proportion of rhegmatogenous retinal detachments. Now, why does it occur? Posterior vitreous detachment is a key dynamic process that causes retinal tears and detachment, and this is known to occur earlier in those with myopia. Axial myopia is frequently associated with peripheral retinal thinning and development of lattice retinal degeneration. And the combination of premature posterior vitreous detachment and peripheral retinal degeneration would explain at least partly the increased retinal detachment risk in patients with myopia. Now, why does it occur after refractive procedures? There have been various mechanisms postulated: the use of suction rings, excimer laser shock waves, and femtosecond lasers. All these have been suggested in the past to predispose patients to develop rhegmatogenous retinal detachments after corneal refractive surgery. And surgical procedures like refractive lens exchange in eyes with high myopia can increase the risk of retinal detachment, as does complicated cataract surgery. Now, does the risk change based on the procedure? PRK, LASIK, and SMILE historically have the same risk as eyes without the procedure, but possibly the risk is less with SMILE compared to PRK, LASIK, and femtolasic. Phakic IOLs and ICLs probably have the same risk as other myopic eyes, but if you are planning a refractive lens exchange in eyes with myopia more than 10 diopters, the risk is nearly double than eyes that did not have retinal surgery. And this has been published in a study in 1999. Now, coming to the important question most of us would want to know is, which eyes would I treat prior to any refractive procedure? Basically, it does not differ. Would you be treating those eyes anyway, or would you be treating them specifically? All high-risk eyes, all symptomatic tears. We know that Stickler syndrome now has a strong recommendation for laser photocoagulation. But the gray area is eyes with extensive areas of lattice, say 2 rows of 360-degree lattice that nowadays most of us would be hesitant to even touch, definitely form a gray area. And these indications, these treatment recommendations were published in an IGO in December 2020 on how to screen and treat retinal degenerations prior to refractive surgery. Another question we always wonder is, how long is a safe gap between laser and the procedure? If you look at pathology, The earliest evidence of adhesions post-laser is 2 to 4 weeks, and most of us would consider that as sufficient. But it takes almost complete development of a chorioretinal scar, 4 to 6 weeks, for it to be strong enough. But what most of us forget is that all these eyes may not have a posterior vitreous detachment, and our treatment may induce a posterior vitreous detachment. And for PVD to evolve completely, it may take almost up to 6 weeks. Now, literature has very scanty evidence on effect of pre-treatment absence or presence of posterior vitreous detachment and influence of either on the outcomes. And in view of the above, it's probably better if we were to re-evaluate the retina prior to the procedure, and I'll show you why. Explain to the patient the symptoms of retinal detachments like flashes, floaters, metamorphopsia, or field loss. And it would be ideal to examine the retina 6 weeks later and at every routine follow-up. Now, this is one of my patients who's now 30 years old with a -10 diopter myopia. He is a genetically confirmed Stickler syndrome. I have operated 2 members of the family. The father also has Sticklers. You look at his fundus, he has multiple radial lattices with extension almost going up to the optic disc. He underwent scleral buckle surgery in the left eye at the age of 15 and now is maintaining good vision in that eye. At that time, he underwent laser photocoagulation to peripheral lattices and breaks, and he has been on regular follow-up since then, and these radial lattices have remained as such. Recently, he presented with a few floaters, and if you look at this picture, it shows that there is a small retinal hole at the edge of the radial lattice superiorly and similarly at the edge of the radial lattice inferior. He was asymptomatic, but it appeared as if PVD was beginning. So I suggested laser to the breaks in the right eye. He came back for a follow-up 6 weeks later. You see that these treated areas are well surrounded by laser, but we also see that the posterior vitreous detachment edge has advanced, and now we have new breaks at the anterior edge of the lattice with subretinal fluid. And he is still asymptomatic and likely to remain so because the fluid is anterior. So this is why you would definitely need to examine your patient even after doing prophylactic laser, especially if you feel that the PVD is still in evolution. So what is important? Even when a patient has had adequate treatment, you need to evaluate the patient following the same and subsequently, because literature tells us that 5 to 14% of patients found to have an initial retinal break can develop additional breaks during long-term follow-up. And this is regardless of whether these breaks were treated and how they were treated. New breaks are particularly likely in eyes that have had cataract surgery due to, again, induction of posterior vitreous detachment. And what we should not forget is patients with degenerative myopia, which form a large proportion of our patients going in for refractive procedures. Myopic traction maculopathy, including posterior pole breaks and retinal detachment, can occur at any time, and there's no way you can avoid it. Now, this is a gentleman who had a -18 diopter refraction prior to cataract surgery. There were no peripheral retinal lesions. Post-cataract surgery, he was a happy man with a planar refraction for 4 years, and then presented with a sudden onset of flashes and floaters followed by field loss. Now, if you look carefully, he has a nasal retinal detachment. There is a peripapillary staphyloma with atrophy. Look carefully, there's this tiny peripapillary break, which you see better here and see better in the red tree, and confirmed on the swept-osity around the disc. So these are things you can neither predict nor you can treat, but they have implications when you need to talk to the patient as to why they are developing complications of myopia, even though the refractive error is not zero. Now, the final question we need to ask are what are the problems I would face as a retinal surgeon in an eye with retinal detachment post-refractive surgery? The most difficult for all of us are the patient expectations, because they want to remain at zero. They do not want any change in the refraction. And that takes a lot of counseling. Some of us allow this to influence our choice of procedure, but possibly we should not be doing it. Intraoperatively, we have numerous visualization issues. Something we need to be careful is LASIK flap dislodgement, distortions in an eye post-RK, which all of us have faced at some point in life, the presence of ICL with cataract, or a phakic IOL with or without cataract. And post-operatively induced myopia and astigmatism, which is most common post-scleral buckler and cerclage. But post-vitrectomy, the risk of cataract, astigmatism, and glaucoma is higher. Now, this is a 45-year-old gentleman with degenerative myopia in both eyes who had ICL in the right eye and possibly a clear lens extraction with IOL in the left eye. He had a long-standing retinal detachment in the left eye and poor vision, but a recent drop in vision in the right eye due to posterior pole retinal detachment with macular hole. Now, if you look at the right eye, he has an ICL, he has an antler subcapsular cataract, he had an axial length more than 30 millimeters of mercury, 30 millimeters. So this was a challenge. This was the preoperative swept source OCT. You see the hazy view, but it confirms that there is a partial posterior vitreous detachment, a macular hole, and posterior pole retinal detachment. And this patient underwent successful surgery. And you see that the posterior pole has now flattened. This is an oil-filled eye, and this is his fundus picture. And the surgeon for this was Dr. Pradeep. Now, this is a patient who, one of my own patients, who was a 28-year-old myope with a family history of retinal detachment, some laser for lattices in both eyes, following blunt trauma, and seems to have discussed refractive surgery with the ophthalmologist, which is why laser was done for her. However, she had floaters and vision loss in the left eye for 1 month. She had broken her existing glasses, so there was no prescription at hand, but the fundus suggested that there was an anisometropia with a higher power in the left eye. Post-scleral buckle in the left eye, her refraction was minus 6.5 diopters, and she improved to 6.9 N6. The right eye additional laser. And now this is a question yet unanswered. She wants to consider the option of refractive surgery. So this is something we need to debate upon. So to conclude, eyes with lattices and high myopia, they require a pre-procedure counseling, detailed counseling, the risk of retinal detachment. You need a detailed retinal evaluation with documentation of all findings, such as wide-angle fundus photograph and OCT in eyes with degenerative myopia. We know there's an increased risk in eyes undergoing refractive lens exchange compared to other procedures, and this may indicate the need for more aggressive prophylaxis. If the lesion is symptomatic, wait for PVD to be completed if it's evolving. If the lesions are extensive and asymptomatic, balance the risk-benefit. And we should remember that PVD in degenerative myopia is different. And we have other retinal complications in degenerative myopia that may warrant surgery or intervention later. And yes, can we do post-retinal detachment refractive surgery? That's a question. So thank you very much. And thanks again, Swapnesh and Preetam and BOA for inviting me.
Thank you, madam. Thank you so much. Madam, one quick question. Any medico-legal aspect to this particular topic? Like suppose we decide not to laser a particular case, and he lands up with a detachment post LASIK surgery 6 months later. Are there any guidelines published anywhere which can be used as a support?
No, I think as long as the counseling has been good for the patient and whatever was there has been treated adequately, you've given enough time for laser reaction to form, I think then you should be covered. It's usually when the excuses given are different, then the problem arises. Yeah, I think I'll be now introducing, gives me great pleasure in introducing the next speaker, someone I thought was very cool. And yes, he is amazing at interpreting and looking at imaging techniques. Very happy to introduce Uni Nair, who's going to talk about stress and CSR.
Thank you, madam, for the introduction. It's always a pleasure sharing a dais with you, and thank you to Dr. Preetam. Thanks to Dr. Preetam and Dr. Swapnesh for the invitation. Just get things in order. Okay, are the slides visible?
Yes, sir. Yes, sir.
So just put the topic as stressed about CSR. And these are, we'll start with a few images in which there is nothing to worry about CSR. It's a spot diagnosis. And when you see the ink blot leak, you think, okay, that's an easy case in my OPD. But I'm just going to be here to throw a little light on some of the more intriguing aspects of CSR. So I found out 4 stress points. That is nomenclature, multimodal. Are we dealing with 2 diseases or 1? Strange point. Choroidography, are we missing the point? And management, we are currently hands tied. So what's in a name? So to my surprise, there's a very good definition for CSR. That is, there are 2 major criteria. That is the presence or evidence of subretinal fluid, and the presence of RP alterations, which you have to demonstrate by autofluorescence, spectral luminosity, or infrared imaging. But there are also 2 minor criteria. That is, the angiography criteria are relegated to minor criteria, and thickened choroid. So this is a definition of CSR, which probably is very redundant in our clinics. But the nomenclature is important. So by definition, currently acute CSR, it's a big range, anything that resolves within 3 to 6 months. Recurrent CSR is a new episode after a period of inactivity, which has been pegged at 4 months sometimes. Persistent CSR indicates SRF that has been lasting for more than 4 months. Now, again, there are 2 things that are added to this. What do you mean by inactive CSR? That is when you have a prior evidence of subretinal fluid, but no current disease. And what do you mean by chronic CSR? This is a very, very, very strange definition now. Widespread decompensation with or without the presence of ongoing subretinal fluid. So these are the definitions that have been described. And this is a brand new classification of CSR, which is in which it is divided into simple and complex depending on the number of areas, disc areas involved. Complex if it is multifocal, and each is divided into primary, whether it's a first known episode, recurrent, whether you diagnose recurrence, or resolved, that is in the absence, diagnosing the area of involvement in the absence of SRF. Added to this are 3 things, where if it is persistent and you see the SRF more than 6 months, in the presence of outer retinal atrophy plus minus, or the presence of a CNBM. So this is a new classification of CSR by the international group. So to recount, a primary CSR, first known episode, a recurrent CSR, you have evidence of resolution and it comes back a resolved CSR. Currently, there is absence of SRF and OCT. 2 new features or 2 new nomenclature that are there is something called FIPEDs, or flat irregular PEDs, and SIAs, shallow irregular RP elevations, which are important because they may harbor macular neovascularization inside. So these are a few points I'd like to throw. When you have an acute CSR which is resolved, okay, this is a question. Should you consider it differently if you have a pachychoroid or epithelopathy in the other eye? That is, you have an evidence of a previous attack. Would you call a current attack as an acute CSR? These are lacunae in the definitions. A non-resolving or persistent CSR, which we call for 4 months. When you find a new leak, and the new leaky, a new leaky point in the presence of CSR, would it be considered as a new attack and a recurrent CSR in the presence of an acute SRF? Recurrent CSR, again, if the leak is at the same place or very close to the original leak or in a totally different place, would you consider it to be recurrent CSR? And when you, in the definition of chronic CSR, it is defined without fluid. So if you see changes in the RP due to pachychoroid, what do you define it as? Would you call it a chronic CSR, or would you call it a pachychoroid spectrum disease? So these are the confusions. This is one such example where you see an area of RP atrophy, but whether you will call it as a resolved CSC or whether you will call it as a pachychoroid thickened epithelopathy. And suppose you get an image like this. You have a small areas of RP alterations, you have fibrin, you have a vacuole. Is this recurrent? Is this chronic? Or is this persistent? So there are still a lot of stressful deficiencies in the definition of CSR. So multimodal living, this is the highlight I'd like to do in this talk. Are we dealing with 1 disease or 2 disease? And the key to all of this is autofluorescence. When you have a CSR, it's very interesting that more than 70% of the eyes have an area of hyperfluorescence at the point of the leakage. You can see in this area, you can see this is a point of the leakage. There is an area of hypo autofluorescence at this point. So As the disease progresses, this hypoautofluorescence becomes very patchy, hyperautofluorescence, and which may remain after the resolution of the subretinal fluid, like a stigmata that the disease has happened earlier at that particular point of time. So the evolution of autofluorescence goes through granular patterns to complete hypo when the RP is totally atrophic, the presence of gravitational tracts with initial intervening spaces normal, and then they become affected in the chronicity of the disease. So this is what we're talking about, hyperautofluorescence in the acute phase, evidence that there was an involved patch when the fluid goes away, gravitational tracts, all evidence of the changes of the RP at that point. So over time, when the intervening areas become involved, the nature of the disease also changes. And there you can get skytic changes and CME. So this is what I'd like to stress. Are we dealing with a disease where you have a singular point first, like a prodroma, which goes into multifocality later, and later grows between the RP damage, and that is a real disease, a chronic widespread RP decompensation. So by definition, chronicity is defined very arbitrary as 6 months. But the newer trials all mention that chronicity should be defined only by imaging techniques and the RP changes. And these are some of the RP changes: RP thinning, cystoid macular edema, clumping, schisis, tracts. So all of them over there. So the key in defining or understanding CSR would be this: how to differentiate multifocality versus diffuse RP involvement or RP epithelopathy. That is, looking at the autofluorescence to see whether the intervening RP is normal. So here you have 2 points of involvement, which constitutes probably a multifocality. And here you see a disease where there is diffuse RP atrophy and the intervening areas are involved. And later, the decompensation of the RP produces changes inside the retina, like cystoid changes and schisis. Let's see what we understand by choroidal. We all harp about choroidal thickness. We say that in the involved eye, the choroid is usually thicker than the fellow eye, but both eyes have generally a thicker choroid than a normal person. This is our concepts of CSR, and this is how we measure. We see large areas of choroidal thickening, and that helps in our diagnosis of CSR. But some key features you see on the NFAS scanning. Here on the picture on the right-hand side, you see the network of dilated choroidal vessels, very, very brilliantly over there. And in this, you can see the top left-hand corner, you can see this is a reverse image of the choriocapillaris, in which you see dropout areas. So what do we find? You see dilated large choroidal vessels, the inner choroidal layer gets thin, and the choriocapillaris is deficient or displaced. We don't know yet. But from thinking that the disease CSR originates from a primary atrophy to choriocapillaris versus whether it is because of compression and displacement of outer choroid, all we really know is that there is a relative deficiency of the inner choroidal circulation. So I would like to name this missing the point. When you think of CSR, you only think of one thing: focal points, ink blot, smokestacks. But probably the disease is slightly different. You have a larger area of choroidal abnormality, and then you have areas of RP abnormality, which is smaller, and then you have areas of leak, which is the smallest point. We treat the leak, therefore we are missing the point. The point is not a point, it's a larger area of choroidal abnormality. This is brought out when we treat the disease using FA and ICG from a management perspective. FA identifies the leak and the extent of RP damage, identifies multifocality and DRP, but ICG is going to find out the background disease, what is happening, and where you actually have to identify the problems at. So we all know we treat when there's persistent fluid, visual loss, rapid recovery is required, or poor outcome. And we know that PDT is probably the standard, and that is why I mentioned first that treatment is now hands-tied. PDT has been unavailable for some time. So I'm just going quickly through 4 of the options now. Dorzolamide, topical dorzolamide has been found to facilitate absorption of fluid by 1 or 2 studies over there. It reverses the polarity and therefore causes rapid absorption of the subretinal fluid and intraretinal fluid. So after dorzolamide treatment, you find that there has been a resolution of the SRF. Another drug that we're all looking into is eplerenone, in which it causes rapid resolution and a persistence of improvement in visual acuity in this particular study up to 5 months. And this is a meta-analysis of all the studies, and most of them show good results with eplerenone. And the dose is 25 to 50 mg per day, is well tolerated. There is no consensus in how long it has to be used, or how can you just suddenly take the patient off, and what to expect and when to expect a recurrence is not exactly clear. So the principal study is that nearly 75% patients have resolution of SRF in chronic CSR, but a good 10% to 12% do not respond. Spironolactone has nearly the same role as eplerenone, but the side effect profile is slightly higher, and the recurrence rate while on treatment was found to be quite significant also using spironolactone. Now, another option instead of PDT was considering micropulse laser. The studies say that there is an equally good effect to PDT when done properly within a particular period of time. However, one interesting two studies have come out saying that the 577 nanometer laser is what is recommended, and not the 532 nanometer beam laser micropulse. So CSR is an evolving disease that attracts multifocality, contiguous damage, and then decompensation. This I like to repeat again and again. So there are two recurring things. I like to call it the law of greater pathology. Always remember that the area you see on regular angiography, the disease is in a larger area than the area you largely see. So all your therapeutic strategies in your mind should account for that. And the second, I like to call it the law of progressive characterization. I like to think of acute CSR as a prodroma proceeding towards a chronic CSR, which is a real disease, widespread disease, which actually causes visual degeneration. Therefore, the disease progresses through a particular stage to reach, and our point of time is to intervene before it reaches that chronic CSR stage. So to take the take-home message, I would say is that don't take it so lightly, CSR. It is two diseases in one package. It is not the SRF that should worry you. It is the atrophy and the cystoid changes. It is not a disease to observe. PDT is a very superior form of treatment, and unfortunately, it is unavailable now. There are evolving medical therapies which have not gained the entire confidence of the medical community, but at this point of time, we should really look into those. So thank you for your patient listening, and I'd like to acknowledge my team for helping me put up this presentation. Thank you.
Thank you, Unni, for giving us a wonderful overview of CSR and the concepts and management. It's now my pleasure to invite Avinash to give us some pearls on vascular occlusions, and very proud to have had Avinash with us, and his clinical skills are amazing, as well as his interest in teaching. So welcome, Avinash.
Thank you for those kind words, Dr. MPV, and I thank Swapnesh and Preetham and BO and MOS for giving me this opportunity. Unlike the previous talks, my talks is going to be pretty simple and probably for day-to-day practice of one condition which is more commonly the second most retinal vascular condition following diabetic retinopathy. The first challenge is when we have patients with central retinal vein occlusion, ocular ischemic syndrome, and diabetic retinopathy, saying by side to side. The one point which would help us to make a diagnosis of central retinal vein occlusion is to look out for the tortuosity in the venules. And once you see a tortuosity in the venules, then the diagnosis of central retinal vein occlusion or venous occlusion is quite evident. And having made one, so the next thing what we do in the course of evaluation is we preempt in making a diagnosis whether we are dealing with an ischemic or a non-ischemic. And many times when you look at hemorrhages is the one which drives us in terms of clinical evaluation in an acute setting. Mind you, I'm underscoring the word in acute setting. The superficial hemorrhages, the plenty of hemorrhages which drives us towards making an diagnosis of an ischemic central retinal vein occlusion, which should not be the case, because the diagnosis of ischemic or non-ischemic is made on constellation of features, just like visual acuity, relative afferent pupillary defect. And mind you, the extensive retinal hemorrhages are the least reliable. And if possible, if you have a wide field capillary fluorescein angiogram where you can see an extensive capillary non-perfusion, and in ERG, you see the B wave amplitude is lower. So on constellation of the features, we make a diagnosis of ischemic, just not based on hemorrhages alone. The most common complication which we get to treat in a patient with central retinal vein occlusion, apart from the macular edema, is the anterior segment neovascularization. But if you see an optic disc collateral, the chances of anterior segment neovascularization developing in these cases are relatively less, and that's the clinical sign which it would give us when we observe it. And having discussed about anterior segment neovascularization, the most commonest indication where we treat is macular edema for central retinal vein occlusions. And now, how do we elicit that this macular edema is of recent onset on clinical evaluation is by looking at this white dot in the center of the fovea. If you look at this white dot, which is due to the enhancement of the xanthophyll pigments, is one sure shot clinical sign we are dealing with a macular edema of a recent onset in central retinal vein occlusion, or a matter of fact for any other etiology of macular edema. Now, vitreous hemorrhage in central retinal vein occlusion is a very rare manifestation. So if there is a vitreous hemorrhage which happens, most of us tend to look towards a neovascularization, but it does not happen in the acute stage. If in an acute stage we get to across a vitreous hemorrhage in a patient with central retinal vein occlusion, always think for a breakthrough vitreous hemorrhage. And because of the risk factors in diabetic retinopathy and in hypertension and central retinal vein occlusion all are jumbled up or one and the same, there is a good possibility sometimes we get to see patients with coexisting diabetic retinopathy with central retinal vein occlusions. And if they do coexist, there are three possibilities which can happen in these patients. They can have an asymmetrical progression. There's a higher chance of neovascularization, anterior segment, and also the posterior segment neovascularization. And to a certain extent, there's increase in the lipoproteins in the retina. My next clinical pearl would be on how to identify in a delayed case if the macular edema or cystoid macular edema in a patient is because of central retinal vein occlusion. So if we look into the temporal periphery, we get to see the hemorrhages, and the hemorrhages in the temporal periphery are the last to resolve. So next time when we get to see a patient who has a macular edema and you're searching for what could be the possible etiology, just peep into the temporal periphery, and if you see the hemorrhages there, then you think of a possible etiology of a central retinal vein occlusion. Not uncommonly, you see there's a loss of transparency in the macular area in a patient with central retinal vein occlusion, and that goes by the name of patchy ischemic retinal whitening, or abbreviated as PIRW. And what does it signify? It signifies there is an cilioretinal arterial insufficiency we get to see in these patients. Having said that, patchy ischemic retinal whitening can also be seen in many other conditions other than central retinal vein occlusion. Now, this is a very beautiful slide where it's an extension of the cilioretinal arterial insufficiency to going on for occlusion. So, cilioretinal arterial occlusion can happen due to three conditions, but CRVO is one of the commonest we get to see. And one additional clinical pearl, what I can share is if a patient presents with a cilioretinal artery occlusion, the chances of macular edema in these patients can not be as high or as not as much or severe as those without cilioretinal arterial obstruction. So that's an additional point when I made about the whitening, the cilioretinal artery obstruction, and the decrease in the height of macular edema if they are associated with cilioretinal artery occlusions. Now, this is a point which I had conveyed earlier. In an acute setting, the amount of superficial hemorrhages should not make us make a diagnosis of an ischemic central retinal vein occlusion. But that's not true. The hemorrhages should not influence in a delayed setting. So we know that in indeterminate type, some of these central non-ischemic might progress on to development of the ischemic type. And we do have it in our discussion with the patients right at the moment, because this is not under our purview or not under control, either to preempt or prevent from happening. So the clinical clues we can get is the resolution of superficial hemorrhages will start happening, but sometime during the course, you will have this deep blotch intraretinal hemorrhages which starts appearing. And it is then when we have to be very careful and probably involve the patient in a discussion. There is a good chance that you can go in for the ischemic type of central retinal vein occlusion and associated new vascularization which can happen in the anterior segment. Now, there are some rare circumstances where there would be a need to flag when a patient presents with central retinal vein occlusions. And there are 4 instances when we have to flag them. One, if they're present with bilateral. Second, if they're young patients. And third, if they're associated with extensive right-centered retinal hemorrhages. And fourth, if there is an associated arteriolar occlusion. So these are the 4 important times where we have to flag when a patient presents with a central retinal vein occlusion. Now, having spoken about when to flag and the importance of deep retinal hemorrhages, where it goes from the non-ischemic to the ischemic, another rare entity where there is of a recurrent retinal vein occlusions. So when it starts with BRVO, another time it can go on with the hemiretinal vein occlusion, then go on with the central retinal vein occlusion over a period of time, as seen in this patient. Always rule out obstructive sleep apnea in such kind of patients if they don't have any other risk factor associated which could attribute to the involvement or the development of recurrent retinal vein occlusion. Few features on OCT which usually signify retinal ischemia is one is drill. We all know what drill is about when we are not able to clearly identify more than 50% of the inner retinal structures. So what does it convey to us? Patients who drill usually do not have a good visual acuity even with anti-VEGF injections than in patients who don't present with drill. So this is important for our prognosticating purposes, that patients present with drill, the visual gain is not similar to those patients who don't present with drill. Another OCT manifestations which again signifies retinal ischemia is the presence of an hyperprominent middle limiting membrane, where you can see here. In the presence of prominent middle limiting membrane, which usually signifies which at the level of the inner synaptic portions of the outer plexiform layer. And if we get to see one, this is another clinical marker or a diagnostic marker which helps us that these patients can progress from the non-ischemic to the ischemic central retinal vein occlusions. So having spoken about 2 previous markers, drill and prominent middle limiting membrane, the next OCT feature which I would like to share is the PAM, paracentral acute middle maculopathy, where it's again a sign of acute retinal injury where there is an hyperreflectivity of the inner nuclear layer. So this is also an ischemic insult in inner nuclear layer, but it is not as profound as a prominent middle limiting membrane prominence in terms of prognosticating of conversion from the ischemic or non-ischemic to the ischemic ones. And OCTA is something which is catching up. Many people are having OCTA and they have their own indications and advantages of complementing imaging modality to fluorescein angiogram. We all are aware of the fact that it's a non-invasive modality. We are all aware of the fact that it can image both the superficial capillary plexus and the deep capillary plexus. And what additional information what we have learned is when we demonstrate an enlargement of the deep capillary nexus, peripheral capillary arcade, especially the deep peripheral capillary arcade, it really coincides with the presence of retinal peripheral ischemia seen on fluorescein angiography. That additional information we are able to observe and in OCTA, which would help us in prognosticating or keep a watch on this patient, that these patients might progress from the non-ischemic to the ischemic type. Now, glaucoma is one of the important risk factors for the development of central retinal vein occlusions. So if a patient has a glaucoma and develop a central retinal vein occlusion, it is important that we have to lower the pressure by 30%. And it is also important that we have to perform the paracentesis either before or after the administration of anti-VEGF injections and try to avoid a deposteroid in these patients as much as possible so that they don't have a recalcitrant raise in intraocular pressure. And not uncommonly, sometimes we get to see an increase in cotton wool spots after an anti-VEGF therapy in patients with central retinal vein occlusions. And the reason why I'm bringing out this point is this should not tell us that this patient is progressing to the ischemic type. So this understanding, this is not a marker for us to indicate that there is a progression from the non-ischemic to the ischemic variety. And we have various modalities of drugs available in the management of macular edema in retinal vascular occlusion, but sometimes some of these don't work and we might have to switch. So the indications would be when there are less than 5-letter gain or there is less than 20% reduction in edema after 2 injections, then there is a need for us or look into the possibility of shifting to another drug modality. Now, moving on to the branch retinal vein occlusion, I did touch upon the deep inner retinal hemorrhages in 2 aspects. One is in the deeper retinal hemorrhages help us to prognosticate that these patients can develop ischemic component in the future if they do have it in evolution. Similarly, in cases of branch retinal vein occlusion, we also see a component of deep retinal hemorrhages, which are usually overlooked by the superficial flame-shaped hemorrhages, because we have been taught that superficial hemorrhages is very synonymous with branch retinal vein occlusion, but we just tend to overlook these deep blotch retinal hemorrhages, which are more towards the mid-periphery and indicates a vascular endothelial injury as seen more commonly in younger individuals. Now, how about macular edema in a patient with branch retinal vein occlusions? Now, we get to manage a patient with the macular edema due to a branch retinal vein occlusion, and then the macular edema settles or remains stable. Sometimes these patients come with further decrease in central vision, and when you see that the macular edema, which was stable till then, either was flat or it had attained stability, started increasing, or the number of cysts starts increasing. It is here where you have to entertain the fact that when there is a recurrence of macular edema few months or even years after resolution of retinal vascular occlusion, think about a possibility of decompensation of the collaterals in these patients. The next, another pearl which I would like to share again pertaining to macular edema in branch retinal vein occlusion, but this is not of an acute setting. The previous example which I gave is also of a chronic setting, maybe months or years after it had become stable. Now, this is recalcitrant macular edema, and many times we see that when you keep injecting these patients, especially in the chronic branch retinal vein occlusions, the edema don't tend to resolve. And if you image them, you will be able to see the majority of them would have developed aneurysms. And when they have developed the aneurysms, when these injections don't resolve, or before labeling them as recalcitrant, try the age-old laser photocoagulation in these patients, which would help in the further reduction of the macular edema in these patients. So before I end, this would be my last slide. What I discussed about the occurrence of the microaneurysms or aneurysms in a patient with in a chronic setting of branch retinal vein occlusions. Now, the point which I'm going to make here is the aneurysms in the branch retinal vein occlusions or chronic venous occlusions are usually larger than one would get to see in diabetic retinopathy and central retinal vein occlusions. So venous aneurysms are larger than the ones which usually happens from the capillary side. So with that, I thank for the opportunity given to me by Swapnesh and Preetham, and I completed my 25 clinical pearls on venous occlusions. Thank you.
Thank you, sir. And every slide was like a treasured pearl, and thank you. It would be very helpful for the fellows as well as the general ophthalmology audience. So the next talk is by Dr. Prashant Agnihotri, sir, and he would be speaking on COVID-related vascular catastrophe.
Good afternoon. The BOA, the MOS, and all the office bearers for giving me this opportunity. I actually, this topic, I thought I have, to share with you. One second, let me share my screen with you. And we are really, getting out of one pandemic and getting into another epidemic. So that is where I thought, let me share with you what is our concern now, because we are seeing these numbers increasing every day. I think the last yesterday was 10,000 crossed. So I thought let me talk to you about ocular mucormycosis and how it is affecting our day-to-day practice and our understanding of the whole disease. Now, we all know that it's a very aggressive fungal infection, which is associated with high mortality and a high morbidity. Basically, the spores are inhaled, they reach your nose, the sinuses, enter the intact epithelium, they erode, or if there is an injury or whatever, it reaches the sinuses. From sinuses, it reaches the orbit, and from the orbit, it goes to the cerebral areas where it becomes rhino-orbital cerebral mucormycosis. And we have the only one drug, which is the wonder drug, is amphotericin B, which is again not available so easily. So it's a blue fungus. They call it as black because it leaves behind black dead tissue. It's present all over as spores. And as I said, it has become an epidemic proportion. The causes are many. We don't really know which are the causes, but prolonged steroids, uncontrolled diabetes, diabetic ketoacidosis, and use of TOSI, there are few things which are blamed. And basically, it causes thrombosis of the feeding artery, which causes tissue infarction. And further, the dead tissue, there is a fungal invasion, which causes all that inflammation. So basically, all these patients who are post-COVID, they are suffering from two things. One is that their immune system is dysregulated, and this is basically a prothrombotic or a thrombotic event, which results into extension of this.
Sir, we can't hear your voice.
My voice now?
Still dim.
So,
yeah, now it is better.
It's audible. Okay, I'll speak a little louder.
Yeah.
So we it can invade any tissue, and it can result into all these things, including vessels. It causes loss of vision, which could be moderate to severe. It can cause optic neuritis. It can cause vascular occlusions. One thing which you should understand is that the only investigation which can tell us how much mucor has invaded your body is gadolinium contrast MRI. Please do remember that you should always order a gadolinium contrast MRI with T2 weighted scans with fat subtraction. Why am I saying this is because this is the only investigation which can tell you difference between the vascular and the non-vascular avascular areas, because you have to debride all possible avascular tissue along with mucor. So the only report I could see where we can have medical treat orbital involvement is this injection of amphotericin B. This is reported in AGO last year. So it was happening last time also, but now it is becoming very high. You give 2 injections at 3 doses in 3 days interval, and the vision improved in this particular patient. Probably we must know that when we are waiting for this some major surgery, we can give the patient retrobulbar injection if you think that the optic nerve is involved or there is an orbital invasion. So a dose of 1 ml, 3.5 milligram per ml, which is a normal amphotericin B, easily available, can be given in 3 days interval. Just remember, you have to give 2 ml of lignocaine before injecting this. It may cause little edema or the conjunctival chemosis, but that's part of the deal. And this is just a mucorales. Just to show what sort of cases we are seeing it now. This kind of an extensive orbital involvement with invasion of the skin, a dead black fungus growing, and the person is so toxic that this person needs exentration. So this is where I firmly believe that such patients need exentration. And once we do exentration, we have debulked the tissue, and then we treat it with systemic amphotericin B. Locally, we can apply amphotericin B gel, which can kill off the mucor locally present. And this is what happens. Basically, when I wanted to talk was, there's something I want to show you, which is, these are all the post-exentration patients, where you can see the orbital apex, but this is the limit. as an eye surgeon, when you're excentrating, you cannot go beyond this. You cannot go, and most of the time, the mucor is going beyond this. Mucor is invading orbit through the inferior wall or the medial wall, but it starts going posteriorly through the sphenoid fossa, the pterygopalatine fossa, and that is where I believe that this is what is the procedure of choice. If you want to save the eyeball, and this particular patient, when I'm starting this video, this is borrowed from my friend ENT person. See, this is through the fess orbitotomy, I call it. This is endoscopic sinus surgery. A 37 years old lady, bilateral blind, and bilateral invasion of mucor going posteriorly. So this is the process by which they are debriding it. They're using that a debrider. They are using a burr where they have to remove. You're seeing the optic nerve. He's gone lateral to the optic nerve. He's removed the medial wall. The whole medial wall was involved with osteomyelitis, mucor, and now the surgeon
So please be a little bit loud.
All the fat has been invaded by the mucor, and okay, I'll increase the. Now, can you hear me? So, yeah, this is just, you have to watch this surgery because this is something which changed my mind about exenteration. You remove all this dead or involved fat tissue. You can go lateral to the optic nerve. Here is the apex of the orbit. Here you are seeing the sphenoidal, you are seeing the pterygopalatine fossa, and all this is removed by this debrider. It's like a vitrectomy machine. We remove blood. Similarly, this machine or this particular cutter, it is removing, you're denuding the optic nerve. You're removing all. Can you see how much of mucor is there behind? The lateral to it. Once we separate the optic nerve, you can go see, sir, optic nerve is pulled to medial side, and he has removed all the mucor which is there. Keep removing till you get bleeding or you get a fresh tissue, because that is the only way you can save the life of this patient. Otherwise, mortality in such patient is more than 70%. So you keep on removing till you can absolutely clean up the tissue. The advantage is you are at least a bilateral blind person and doing an exenteration. You can see the eyeball there. Doing a bilateral exenteration is the biggest damage to his psyche, and you are creating another issue by which morbidity is increased. This particular patient was operated about 2 weeks back. Patient is doing well because he has been bilateral surgery was done from the same side. The middle nose there was removed, and the whole eyeball, you can see the eyeball, the optic nerve, everything is being there. So basically, my purpose of this particular presentation was that when a patient comes to you with extensive disease, you can see the pterygopalatine fossa, everything was removed in this particular case, because beyond this is only cavernous sinus. Once it goes to cavernous sinus, then it is beyond us. It goes into the neural field where patient may have infarctions of the brain. Patient will be, the prognosis is very bad. But you can see after removing all the black thing, everything, whatever is left is a healthy tissue. This tissue would be taken care by systemic. You see, your bleeding has started. So we have reached the live tissue. And that's why I said the investigation of an MRI, where we must be able to differentiate between the avascular and a vascular zone to decide how much we are going to go in. And once that has been done, amphotericin is to be given in the doses of 5 milligram per kg body weight or 10 milligram if it is a cerebral thing, and the patient can be saved the exenteration. So this is all what I wanted to show you. Thank you so much. I do not do exenteration unless it's the case which I showed you, where it is exempted because conjugating out. Like in the class, we used to do conjugating out when we do here in this particular case. this is the small message I wanted to give you, that do give it a trial. There is a process by which the ENT surgeons are being trained to do this dextro procedures, and probably we'll have lots of them available to us. So instead of doing exentration, let's think of doing orbitotomy. The FES orbitotomy. Thank you so much, Swapnesh, for this opportunity. I think I was in my time. God bless. Thank you.
Thank you, sir. Thank you. That was a wonderful video of that procedure. The next talk, I will request MPB Madam to introduce our next speaker, Dr. Rupakanti Biswas, sir. He's speaking on fluid management in wet AMD.
Yeah, it now gives me great pleasure to invite Rupakanti Biswas, an excellent clinician and surgeon who's doing very well in Kolkata and has wonderful videos to his credit. We look forward to listening to you, Rupa.
Thank you, ma'am. Thank you, ma'am, for your nice introduction. And I would like to, at the outset, I would like to thank Dr. Preetham, Dr. Swapnesh, Dr. Ragini, and none other than Dr. Lahane, sir, for giving me this opportunity. I think this is the mammoth task is going on. We'll just straight away move to our talk. And I know that we are running short of time. So this is the concept of fluid management in wet AMD. Concept of fluid management in wet AMD is actually being it's a journal ophthalmology platform. So we are I will try to concentrate more for the journal ophthalmologists and day-to-day retina practice. So you can make out from here the presence of fluid at different level. You can see that the red areas are actually the intraretinal fluid and the intraretinal cyst. The subretinal, the grayish area is the subretinal area. And this reddish, the below the RP area is the sub-RP fluid. Now, why it is important? Because if you go back to the CAT study and then see near about 82% of the patient has subretinal fluid, 75% patient had intraretinal fluid, and near about 50% patient has sub-RP fluid. Similar kind of, either of them is present in any case of wet AMD diseases. So now the most important is that over the period of decades, so initially when there was MPS study and other initial studies, at that point of time, FFA was the gold standard for detection of fluid, whether it is the disease activity. Now, once we have moved slowly to the OCT zone, and then we have understand that presence of fluid is one of the most important marker for determining our disease activity, being it is one of the most non-invasive techniques. So even on that basis, all the landmark studies, CAT, Ivan, Lucas, VU, Herber, Rival, all TREX, all the study have clearly shown that when there is an unresolved fluid, you should start treating them. Now, over the decade, when we are following them, now after even the past study post-hoc analysis also showed that there is a disease activity at 5 months and 8 months, and all of them were doing, if the disease activity, those who are not having disease activity of 5 months or 8 months, they are more having the effect at the end of 2 years. So that means the presence of even other studies of other the bodies also have clear-cut guidelines when there is the presence of fluid. We should treat them starting from Retina, RCO, AO, everyone. Now, over this period of decade, we were following these things. Still, the fluid study has come into the picture to confuse us. So what the confusion, the fluid study says, the tolerance of some amount of the subretinal fluid did not actually adversely affect the visual outcome. So that means some amount of the fluid, if you leave it untreated, then the visual outcome does not worsen. So that means, should we not treat all the fluid? Now this is the, so let me put it in a very proper way. So to understand whether the disease is active, the fluid is an indirect evidence of the disease activity. Now, to understand whether the disease is actually active, we need to have a multimodal imaging starting from color fundus fluorescein, ICG angiography, and the recent is OCT angiography. Now, when you have these kind of all disease modality together, you can assess whether the disease is still active or not. And OCT can give you a serial follow-up whether the disease is progressing or not. Now, what is importance of an intraretinal fluid? So intraretinal fluid can get accumulated in a well-defined space and can create in a long follow-up. It can create an intraretinal cyst. Now the presence of IRF and intraretinal cyst at the baseline is associated with the negative impact on the BCVA. Both residual and the new appearance of the IRF is also having a worse visual acuity outcome. So what literature says with this support, yes, the post-hoc analysis of view 1 and 2 is the presence of intraretinal fluid at the baseline has a negative impact on BCVA. So this yellow line is intraretinal cyst at the baseline they have, and this is without cyst. So it is very clear that if you don't have intraretinal fluid to start with, you have the better visual outcome. So the secondary analysis of the CAT study also clearly showed that the persistent intraretinal fluid is associated with the poor visual outcome. So here it is, the blue line is there is no intraretinal fluid, green is there is intraretinal fluid but non-foveal, and red is foveal. So all those three, if you see very clearly, if you don't have the intraretinal fluid, the outcome is much better. Visual acuity gain in terms of later is much better. Even in presence of non-foveal IRF also, you have a better visual outcome. You have a comparatively lesser visual outcome. So the IRF is always have a bad, even the post-hoc analysis of XI shows the new appearance of the intraretinal cyst is also again a bad prognostic marker. So in short, putting together the intraretinal fluid, whether it is to start with or in between new appearance or a persistent, they have a bad visual prognostic factor. What about the subretinal fluid? Now, in some studies, they have shown the subretinal at the baseline and the residual effect are associated with either better or the visual outcome. Now, it is obviously that if you have a subretinal fluid, the baseline visual acuity is always tend to be less. And once you have the resolution of those subretinal fluid, you have a better visual outcome compared to those who are not having a subretinal fluid. So this is a secondary analysis of the view study. The effect of baseline subretinal fluid obviously will have a better visual outcome. Now, this is the secondary analysis of the CAT study says a persistent subretinal fluid did not adversely affect the visual acuity outcome during anti-VEGF treatment. So by this way, in 2016 itself, the fluid concept is already established in this secondary analysis of CAT study. So, but what it is there, now we'll just reanalyze it when I'm discussing the fluid study. Now, the recurrence of subretinal fluid has been associated with the vision loss. So if you have, so in this chart, if you have a no fluid here, and if you have a new IRF or new appearance of the SRF, so even for the 5 to 9 letter also, the chance is more percentage. Even for 10 to 14 letters or higher letter loss also, in everywhere, the new appearance of any fluid, IRF or SRF, is having a lesser visual outcome. Similarly, the ancillary study of Excite has shown that the recurrence of SRF led to poor visual outcome rather than a stabilization of dryness or stabilization of fluids. Now, till 2019, the concept of complete dryness, what we are aiming for. Now, in fluid study, they are telling the tolerance of sub amount of the subretinal fluid did not adversely affect this visual outcome. So the guideline they have given, if you have a subretinal fluid, they have a 2 arm, which is intensive arm, and another one is relaxed arm. So in intensive arm, they have aimed for complete resolution of subretinal and intraretinal fluid. And in relaxed arm, they have aimed for complete resolution of intraretinal fluid, but there is some amount of the subretinal fluid, which is up to 200 micron at the foveal center area. And you have the outcome wise, they have seen that both of them are visual outcome at the month of 2, 12, and 24 is almost similar outcome. This is not less, even the intensive treatment is slightly less rather than the relaxed treatment in long term at the end of 2 years. But the flaws here is up to 200 micron of subretinal fluid is tolerated, but the volume has not been specified here. Suppose if you have the peak of your amount of the fluid, which is not in the subfoveal area and away from the subfoveal area, and you have somewhere around 100 micron of the subfoveal area. So still you can, according to this study, if you follow blindly, then you can observe. The other sign of the disease activity has not been described there in this study, and the role of switching from the higher doses or the other drugs has not been into the scope of the study. And the fluid, they have described that probably the development of the geographic atrophy is one of the reasons for the long term of complete dryness. So, but again, fluid, it has the post-hoc analysis again showed that there is the presence of geographic atrophic area and the presence of fluid area is not matching together. So this theory also does not stand properly actually. So what is importance of subretinal fluid? So in the majority of there are very few studies which actually have studied about the subretinal fluid, but whatever the data is there, subretinal space, fluid in the subretinal space could be an early indicator of the activity or the recurrence of the disease. And in secondary analysis of the CAT study has shown the subretinal fluid did not have any impact on the visual outcome. So if there is no progression of the subretinal fluid, we can definitely observe. So with this, from this, all those things, I am not able to, cover in this area which drug has a better role for resolution of which level of fluid. I don't have any scope of, telling when to switch and what will be the interval of thing. So the main message is there which fluid to be, taken care in which way. So if you are aiming for, if you are following fluid study and if you are aiming for less than 200 micron of fluid at the subfoveal region, make sure that there is no disease activity before you decide it by doing this multimodality of treatment. Once you decide the disease is not active and you have to have a strict follow-up of near about 4 to 6 weeks interval, if there is increase in fluid, reassess the disease activity and treat it accordingly. When there is presence of intraretinal fluid, aim for always complete resolution if possible. Subretinal fluid, early resolution has always the better outcome, and try to prevent recurrence. Subretinal fluid, you can always observe if there is no disease activity or there is increase in the subretinal fluid. Thanks everyone for your nice hearing.
Thank you, Rupak, for a very informative talk. I'm sure the message would have been taken by everyone. Now gives me pleasure to invite the next speaker, Manoj Saswade, a prolific retina specialist in Aurangabad. And it's a pleasure to have known him for all these years. I'm sure he'll do a wonderful job with his talk. So welcome, Manoj.
Am I audible, madam?
Yes, sir.
Am I audible?
You're audible, but
first of all, I
your
would
slides are not visible.
Audible. Wait, 1 second. First of all, I would thank to BO and Dr. Pritesh for giving me this opportunity to speak in front of my mentor, medical retina mentor, Muna madam, who has given me a lot of knowledge. She used to call me to see the lot of interesting cases kept in the department at those times. This is the big topic about that ARMD differential diagnosis. In the perspective of the general ophthalmologist and medical retina. I was talking to my fellows yesterday that this topic, if you learn by heart, this can give you almost 10% of the weightage knowledge in the financial practice also. Because this is a big topic. Second slide. Yes. If you know that the ARMD can be classified into a dry and wet ARMD. You know that the dry ARMD is a hallmark of geographical atrophy and the drusen, while the in the differentiation, not all the atrophies are ARMDs. You can see that there can be a cone dystrophy, there can be Stargardt disease, and not all, even you can see that there's the atrophy in the cases of choroidal dystrophies, and not all the yellow thing is an ARMD. You can get it into the adult onset cohorts, CSME. This is a post-paroxysmal cases. Then these are the cases of the retinal dystrophies, even in the tuberculous abscesses. Well, the hallmark of wet ARMD is being a membrane with subretinal fluid as well as the subretinal hemorrhage, and on OCT the subretinal mass lesion, and on OCT angiography you can see the new vessels in the vascular zone. So the in terms of the dry ARMD, why we want to differentiate it from the other etiologies. There are so many mimics of the ARMD. There, with the advent of the newer multimodal imaging, which has been discussed since morning by various speakers, which has changed the game and give you the exact pinpoint diagnosis of the diseases, these types of diseases. So we know now that not all subretinal hemorrhage or most of the neovascular AMD and mimics are originating from the RP or choriocapillaries. Correct diagnosis is important for the proper management. Life versus short-term therapy is essential, and it is decided on the basis of the diagnosis itself. And the patient can be escaped from the unnecessary treatments of antioxidants lifelong as well as anti-VEGF lifelong. So in the differential diagnosis of neovascular AMD, we have considered degenerative and hereditary conditions like pathological myopia, Stargardt disease, Best dystrophy, angiostrix, parafill telangiectasia, like infective and inflammatory conditions like toxoplasmosis, multifocal choroiditis, tumors like osteoma and melanoma, traumatic conditions like choroidal ruptures, and there are certain miscellaneous and idiopathic conditions like PCVA. Whatever may be the etiology or the mimics, the basic pathology remains that there is a breaks or a brick in the Brooks membrane, and which allow the choriocapillaries to grow underneath the RP or in the retina. That is the basic pathology. And we will start with the pathological myopia. We know that the pathological myopia is having, so in the staphylomatous have lacquer cracks as well as the prostrate spots, which usually disturbs in a diagnosis. Most of the time, even though the clinical diagnosis is clear, we need the help of angiography as well as CT angiography and OCT. And one can diagnose it. And once it is diagnosed, the treatment is easy. Even 1 or 2 doses of anti-VEGFs can regress the disease to a certain very assured level. Another things are degenerative conditions like stars with subretinal neovascular membrane is it is again a clinical diagnosis like in a Sorbis dystrophy. The hallmark is angiographically you can see that there is a choroidofluorescence and SRNM, you can see that. And this is again, once you are diagnosed, then you can give the prognosis very well to the patient. And then there are other pattern dystrophies, various types of pattern dystrophies, where you can see that the RP and the retinal segment dystrophies have been started in. The breaks can occur in these cracks like pattern dystrophies. Here you can see there is a breaks and subretinal neovascular membrane can develop here. And once the diagnosis is over, you can manage the case. This is a West vitelliform dystrophy, is the commonest form of misdiagnosis of age-related macular degeneration. Here you can see that at various stages, here there is a problem in diagnosis. Clinical, even though it is for the retina person, it is a clinical diagnosis, bilateral symmetrical circular lesions in the macular area. But the angiography gives motile hyperfluorescence, but is not the diagnostic. Even some at certain levels, SRF and certain layers, you can get the lipofuscin-like materials. These cases are usually throughout the life, but the main thing is that there is a disproportionate good vision, even despite of such a large, the patient is having 6/9 to 6/6 vision, but this also can give rise to subretinal neovascular membrane. If you see the hemorrhage into these lesions, you suspect the subretinal SRNVM into it and investigate with the multimodality. Another thing is that a familial dominant drusen or Doyne's honeycomb dystrophy. There are multiple drusens all over the posterior port, but predominantly you can see that if they are in the nasal quadrant, and in such dystrophies also you can see the neovascular membranes can develop. Another etiology is angiod strix, which is common in xanthoma elasticum or Paget's disease. There is a papillary atrophy and cracks in the Brooks membrane because of the calcium deposit in these diseases, which leads to allow the choriocapillaries to grow in, and they can develop the neovascular membranes. Interesting thing is that this requires lots of therapy because of the cracks are larger. The problem persists for a longer time. Another differential diagnosis is juxtafoveal telangiectasia type 2, where there is a bilateral symmetrical telangiectic vessel just more over toward the temporal to the fovea. They leak on angiography. Angiography most of the time, if it is a profuse leak, disproportionate leak, then you suspect the retinal neovascular membrane developed into this one. And the OCT also gives you multilamellar cystic changes, which are hallmark of juxtafoveal telangiectasia, or in some cases the scarring occurs, which gives the shadowing. If it is advanced cases, the frank neovascular membrane is developed. You can see this multilamellar cystic changes and thin retina. And on OCT angiography, you can see the neovascularization. The prognosis is bad, but good treatments. There are some precursors of subretinal membranes, which if you identify early, there are drusens and RP atrophy. Along with this is on angiography, you can see the types of lesions which are hyperfluorescent. Later on, they can develop into the condition called RAP, where you can see that the intraretinal is there, new vessels grow, or there is an osmosis between the retina choroid and they form the type 3 choroidal neovascular membranes, which usually grow from above downwards, that is from the retina towards the RP and choriocapillaries. And the condition is again very intractable and do not respond well to the treatment. This is another case of RAP. You can see this is growing from above downwards and internal cysts are there. There are certain conditions in young patients. If you come across with the retinal hemorrhages and fluid and SRF, and cases of subretinal neovascular, there is no conclusive diagnostics, and particularly because of the absence of the drusens, RP atrophy, and there is absence of polyPEDs also. Then such cases, because of the lack of knowledge or even in the presence of multimodality, we do not know what is the exact cause of such SRNVM. So we label it as a idiopathic SRNVM, where we don't know this is a young patient developed the subretinal neovascular membrane. Other eye is almost healthy.
Sir, can we conclude, sir?
Yes, sir. Just fast. Okay. Then there is another group of. There is a group of IPs. You can see that so many subretinal hemorrhages, sub-RP hemorrhages occurs, and the hallmark is a branching network, which is seen on the ICG. This again, you can see that they respond very well to the treatment and to the anti-VEGF. Another group is that toxoplasmosis or infective type of group. Here we have come across with a port that is a punctate outer retinal necrosis, and on OCT you can see that there is a granulomatous lesion. And in toxoplasma, you can see if there is a hemorrhage in the toxoplasma scars, then you can suspect the subretinal hemorrhage, subretinal neovascular membrane. Here you can see that this is the patient which has been treated properly with this one. Then this is a case of multichoroiditis with hemorrhage here, which suspected the subretinal hemorrhage, subretinal neovascular membrane, which after treatment is doing well, and here you can see that dead vessels. Then there are cases like traumatic collapses, which can give rise to this type of subretinal neovascular membrane. Then the new entity which has been discussed with Unni, chronic CSRs and track regions. This should be followed up for years together. This has been patient followed up since 2010. And one fine day he came with the new vessels in the vascular zone and were treated the anti-VEGF. Then other mimics are RAP lesions and region with availability of the multimodal image, one can come to the pinpoint diagnosis of underlying pathology, which is very important to plan the targeted therapy for each and every patient, where we can do the direct laser, PDT, anti-VEGF, and sometimes mixed therapy. To do the proper counseling is very important. If you know the diagnosis, give prognosis to the patients, and study the complex nature of disease spectrum is very important to minimize the injections and investigations. Thank you very much. Thank you, Swapnesh. Thank you, Andrew.
Thank you, Manoj, for that extensive and very well documented collection of cases that mimic AMD.
Thank you, Andrew. Thank you.
And now may I invite the last speaker of the session, Nishant Radke. Nishant, are you there? Yeah. Nishant is also trained in Shankar Netralaya, and now he is in China, and he's going to tell us of his experience of treating PCV in China. So welcome, Nishant.
Nishant, we can't hear you. Nishant, you are not audible.
Yeah, can you hear me now?
Yes, yes. Please go ahead.
Okay. Thank you so much, Muna madam, PK madam. It's a great pleasure to see you. Swapnesh and Dr. Preetham, thank you so much for inviting me. So I will start. I don't want to keep you all waiting. My talk will be about my little experience of treating PCV cases in China. I don't have any financial disclosures, but I do like to thank Dr. Sabyasachi and Dr. Swapnesh. So this will be the outline on which I would be talking. And to give a brief idea, PCV is basically defined as presence of single or multiple focal nodular areas of hyperfluorescence arising from the choroidal circulation within the first 6 minutes after injection of the ICG. And it may or may not be associated with any interconnecting vascular network. So far, ICG is still the gold standard, and nomenclature has been changing. There are reports where they have proposed aneurysmal type 1 neovascularization, another report saying we better stick with PCV. So far that area is still a matter of debate and discussion. There are two primary studies which have tried to evaluate treatment responses for PCV. One of them was the Everest study, which concluded that PDT either alone or in combination with anti-VEGF is better than anti-VEGF monotherapy with Lucentis alone. And the second was the Planet study, where they found that intravitreal aflibercept was not inferior to treatment with combination of rescue PDT. PCV is quite common in Asians, with almost 20 to 60% of cases being diagnosed to have PCV if all these neovascular AMD cases are thoroughly investigated. So it actually becomes an underdiagnosed problem because ICG is not done in all cases. And predominantly, we can say that there are two types, the hemorrhagic and the exudative. So there is a glossary of some terminologies which is important when we are looking at any case with PCV. These are polyp or clusters of polyp, branching vascular network, or any flat irregular pigment epithelial detachment, the pachychoroid spectrum of terminologies, presence of any choroidal hyperpermeability or hyperdynamic circulation, saccular dilatations, double layer sign, complex PEDs, hyperreflective ring under the PED, or any subretinal or macular hemorrhages. This is a small slide showing different types of findings which we get: clusters or solitary or clusters of PED, subretinal orange nodules, a small polyp on OCTA, hyperreflective ring foci under the PED, or double layer sign. This one shows an extent of branching vascular network in a case of chronic PCV. This is the fellow eye of the patient who was undergoing treatment for PCV, where there is a pachychoroid, and here we can see pachy vessels in another patient's OCT, where these vessels seem to cover the entire thickness of the choroid. Choroidal hyperpermeability or saccular dilatations with patchy feeling defects will be picked up easily on ICG. And patients may present with either submacular or massive subretinal hemorrhages as well. So my experience that I'm sharing is not including the first 2.5 years, because the machine which was having the patient data was moved to another center. So I'm focusing only on these years, out of which 8 months I was in India. So I don't have a lot of patients to showcase right now. But what I found is that out of the neovascular AMD cases, nearly 30% were actually having some kind of, out of all the injections that I gave, nearly 30 were having some amount of neovascular AMD. And 20% of this subset was actually PCV cases. I have tried to manage cases on 4 different modalities primarily, either using monotherapy with aflibercept, doing aflibercept intravitreal injection with PDT, and I have done PDT at the start, not later on as per the planet guidelines, or give injection of gas along with an anti-VEGF injection and then defer the PDT. The other option was to do a vitrectomy if there is massive vitreous hemorrhage, and the last option was pneumatic displacement using gas with anti-VEGF injection. So this is a box plot of vision before and after treatment according to these 4 groups, and based on this, my conclusion was that the pneumatic displacement group seems to do much better. This is again the best corrected vision before and after by the variables of their treatment naive status as well as male or female. The age differences, if I try to compare only the PDT and the monotherapy groups, were not significant, but even the pre and post-op, post-treatment vision, even though the post-treatment vision was mean vision was better, the results were not statistically significant. I tried to do a ANOVA as well to compare different groups, but the F value was also not statistically significant, although improvement was seen in terms of anatomy or in terms of vision. All in all, nearly 80% of the cases reached some amount of either inactivity or they regressed. About 22% cases had an active polypoidal lesion. This is a small surgery video to show the kind of spectrum of cases which we have seen. I have done 4 vitrectomies so far for these kind of cases. I'm showing only 2. So we try to dig a well. Sometimes we hit a rock. We are not always lucky, and I'm not going to show anything heroic here, like lifting the retina and all in this particular case. This patient was advised a surgery early, but he came back to us nearly 3.5 weeks later. He's almost 80-year-old gentleman on anticoagulants. So by the time I saw him, the blood had already started getting altered. And when I saw the extent of the hemorrhage, I felt it is best not to touch it. It was having a little firmish feeling to it. So here I'm trying to touch gently and see, and the blood was not looking very easily displaceable to me. So I decided not to do much. I injected gas and did some laser to the periphery and closed the case. The other surgery video is about a patient who has retinal detachment, cataract, vitreous hemorrhage, as well as subretinal echos. And we were suspecting him to have a PCV related bleed. So in this case, the difficulty in cataract is sometimes there is no red glow. So we have to be careful, but we have to try and do the best. Jumping to the vitrectomy. So we always start with the way in which we are taught. After cleaning the vitreous, I found that he has a lattice, which was the cause for the retinal detachment. He had subretinal blood. So I decided to open the lattice and use it as a means to remove the subretinal blood as much as possible. In this patient, I had given sub-tenon urokinase. I am not using tissue plasminogen activator here because it is very expensive when patients are not ready to use it because it is off-label. Whereas outside the eye, patients are ready to use something if it is off-label. That has been my experience. So whatever clots could be removed, gel clots could be removed easily. I removed the other. I just tried to dislodge by agitating the blood by using the back flush, and I removed as much subretinal blood as possible, then used PFCL to milk it as much away as possible. Finally, used some gas and did laser. This patient followed up about a month back. This surgery video was not in, this patient was not included for the statistical analysis. This patient somehow has started improving well so far. These are some representative cases. This is the image of the gentleman who had this massive submacular bleed, which I left as such and just continued with injections. These are some other representative cases where the improvement was till the level of inactivity. This is a case of pneumatic displacement where the patient's macula was reasonably good. The lesion was extrafoveal, so he improved to 1.0. Another case showing reasonable improvement with inactivity for about 4 months. In conclusion, my sample size is small, but anatomical improvement was seen in quite a lot of them. And although the results are not statistically significant, I think they are still acceptable in clinical practice. What I found was that pneumatic displacement with intravitreous injection has promising outcomes, and we should try to do it promptly. And whether we use any blood thinners or whether we use any thrombolytics is different, but we should try to do it always as early as possible. And real world practice and data does not seem to match RCTE always. And thank you all for a patient hearing. Please stay safe.
Thanks, Nishant. You brought out a very challenging cases and very useful way in which conveying what needs to be done when we are posed with such kind of challenges in these tricky situations. And I think we have finished all the talks, though we have overshot on time. To keep it short and sweet, on behalf of the chair and all the speakers, we'd like to thank BOA and MOS for giving us an opportunity, and in specific Swapnesh and Preetham for passing on the invitation to us. Thank you much.
Thank you. Thank you all of you for sparing your time, and do join in for the rest of the webinar, either virtually or you can come on this platform and share your thoughts. Thank you so much. Thank you, Muna Madam. Thank you, Avinash Sir, and thank you all the senior faculty for joining.
Thanks a lot, everyone. Bye-bye.
Thank
Bye.
you.
Bye.
Bye.
Thank you. Thank you very much, madam. Thank you.
Thank you.
Good.